Thank you very much for a very kind invitation to talk about this difficult subject of locally advanced and metastatic urothelial cancer. My name is Hammad Ather. I'm professor of urology and head of urology at Aga Khan University, and this is where I work. Well, locally advanced and metastatic bladder cancer is a difficult clinical condition. Typically defined as a tumor which is T3A+, so tumors which are invading locally into the adjoining structures or invading the pelvic side walls is called locally advanced disease. This may be with or without nodal metastases. An old paper published about over 18 years back in New England Journal of Medicine from various leading cancer centers, in which patients were stratified randomly between chemotherapy alone, cystectomy alone versus neoadjuvant chemotherapy using MVAC in those days compared to cystectomy. And the author showed that combination treatment with cystectomy and chemotherapy provided much better results than cystectomy alone. And when they looked at substratified data, in which this Kaplan-Meier curve shows that patients who have achieved T0 status compared to residual disease, the outcome varies significantly. So potentially, if cystectomy can result in a T0 disease, the overall outcome of these patients would be much better. So by definition, an advanced or unresectable disease includes T4B disease with significant nodal involvement, which is N2+. And this is considered as a stage 4 disease on AJCC system. I'll start off with a case, a 23-year-old male who was operated for a bladder stone about 3 years back in a peripheral hospital, presented with lower tract symptoms and a palpable hypogastric mass. Imaging indicated significant calcification or a stone in the bladder with thick wall bladder. His creatinine was raised with obstructive uropathy. Scan at that time, which was FDG PET scan, done because his creatinine wouldn't allow any contrast studies, show a locally advanced disease, which is definitely T4B, without clear evidence of nodal involvement. His TURBT indicated a squamous cell carcinoma, and he was deemed unresectable because of the local extension of the disease, with some obstruction of his external iliacs as well on the left side. Initial stabilization was done using nephrostomy tube placement bilaterally. His kidney functions improved relatively, however, he still remains somewhere between 2 and 2.5 creatinine with a GFR of less than 25. So there was some evidence of FDG avid areas in the pre-aortic area, but they were not considered metastatic. So essentially, he had a locally advanced disease on the imaging which was available. But because of the local extent of disease, he was considered as inoperable, and he was referred to us. The patient was adequately counseled about the outcomes. However, because of his significant lower tract symptoms, a cystectomy was done. And his histopathology showed a keratinizing squamous cell carcinoma, which was moderately differentiated about 10 centimeters, and it was infiltrative. Some of his margins were negative. However, he has significant positive margins. So, I mean, This is another case, and this is a gentleman that have been under my care for the past 8 years. He initially presented in 2013, 64-year-old smoker, diabetic. His CT and TUR indicated a high-grade papillary urothelial cancer. The CT indicated no extension of disease. So after a re-TUR and reconfirmation of the fact that he has a non-muscle invasive bladder cancer, which is high grade, he was offered BCG induction, which included 6 cycles plus maintenance and 3, 6, 12, 15, 18, 24. And he was quite regular with his follow-up. And his TIC cystoscopies, barring the initial one, have always been negative. He was lost to follow-up during the COVID peak and presented to the cardiologist with some cardiac issues. At that time, his angiography was done, and the angiography showed that he has obstructed coronaries, and he had a PCI performed, following which he developed hematuria, and the further evaluation of hematuria resulted in identification of a left lateral wall and posterior wall mass. He underwent a cystoscopy after this, and we found that there is a significant multiple lesions on the left lateral and posterior wall close to his left ureteric orifice. However, the tumor was completely resected using an R block technique. The significant neoangiogenesis around the tumor. However, the overall configuration of the tumor looked quite papillary type and non-muscle invasive. His histopathology, however, indicated a muscle invasive bladder cancer, which is high grade, and you can see that there is a tumoral infiltration close to the detrusor muscle. He had a raised creatinine, which was 2.5 with an obstructed left kidney. PET scan was done, and the PET scan indicated significant extension of the disease, which is deemed T3B, with a hotspot related to his common iliac on the left side. So he was staged as T3B, clinically T3B with N2 disease. And we discussed options of management, including a radical cystectomy. He agreed to the radical cystectomy. His final pathology came out to be T2B. The nodal status was none of the 16 lymph nodes were positive, including that common iliac lymph node, which showed caseous necrosis, and all his margins were negative. So he had actually a BCG-related granuloma in his lymph node. So the question is, what should be done next about this patient? Should he have regular imaging because of the negative margins and negative nodal status? At 3 months, should an immediate systemic therapy be done as he has failed BCG and is at high risk of metastases? Should local radiation be considered, or chemoradiation, or should he be considered for immunotherapy? Now, if you look at the options of management from the guidelines, we see that patients who are unfit for platinum-based chemotherapy, and he is unfit for platinum-based chemotherapy, there is some role of using immunotherapy with pembrolizumab and atezolizumab, again, depending upon the FGFR3 and PD-L1 status. However, the evidence is not very strong. The immunotherapy is is something which has come up more recently. There are good quality trials. We know that patients who have cancer develop mutation, and these mutations make them immune to the local immune system, which generally recognizes abnormal cells or foreign cells and attack them with the T cells. These T cells remain inactive and do not attack the normal cells because of the receptors. However, some of the cancer cells can start expressing these receptors, and the T cells would not be attacking those cancer cells. In order to block those PDL receptors, PDL checkpoint inhibitors are introduced, and they can essentially make them amenable to the T cell attack. So this in theory looks quite good, and there is initial response as well. However, it is associated with significant side effects, and the data is still not mature to indicate in regular clinical practice. Patients' fertility is another important factor in patients who have locally advanced or metastatic disease, and these can be assessed in various scales and indices. This is the one, the G8 screening tool is what is recommended by the guideline panel. There's another gentleman, a young person relatively, who presented with gross painless hematuria. Histopathology indicated a sarcomatoid tumor, and he has locally advanced disease. This is histopathology, and this is a rare kind of a tumor, which is a pure sarcomatoid cancer, which is really a biphasic malignant neoplasm, which has the evidence both of epithelial and mesenchymal differentiation. As you can see, that there is an epithelial and a mesenchymal component. These are extremely aggressive tumors, and there is very little evidence about the use of adjuvant therapy in these patients. So variant pathology is something that you do see in these individuals, and it's important that one should be mindful of various variant histologies like micropapillary, squamous, and sarcomatoid, which are all very aggressive cancers, something that we reported few years back, and clearly indicating that patients with variant histology have worse prognosis even compared to squamous cell and adenocarcinomas. Well, what else can be done? Well, there's an option of using adjuvant radiotherapy in these patients because chemotherapy generally doesn't work in that situation. So these are some of the papers which have indicated role of adjuvant radiation therapy in patients who've got variant histology after radical cystectomy. I've recently seen this general practitioner, 69 years old male who have practiced for over 40 years, presented to the cardiologist with ischemic heart disease. He's got a poor ejection fraction, underwent URP for obstruction and found out to have a bladder cancer. And this was an invasive, poorly differentiated cancer, which is PSA negative and GATA3 positive. So this is a poorly differentiated urothelial carcinoma. And this tumor was extending from the bladder, from the prostate into bladder or bladder into prostate. The resectionist at that time thought it's moving from prostate into the bladder. However, it's PSA negative and GATA3 positive. So this is essentially a poorly differentiated adenocarcinoma, poorly differentiated urothelial cancer. T4A disease, 69-year-old with many comorbidities, poor heart. And this is one of those patients who would require real counseling in order to make sure that they undergo treatment without any significant morbidity. He's under consideration at the moment for radical cystectomy after optimization of his cardiac condition. So options is chemoradiation an option, chemotherapy followed by cystectomy or upfront cystectomy followed by adjuvant therapy, or upfront cystectomy with imaging. And all these are relatively valid options. However, what patient decides and the treatment has to be tailored accordingly. The other condition is particularly in metastatic setup. The first question that you need to answer according to our guideline is whether the patient is platinum eligible or platinum ineligible. So platinum eligible patients who have got a good GFR of greater than 50 probably would be going through the ideal treatment, which is cisplatin based. However, platinum ineligible patients with lower GFR of 30, they should be considered for carboplatin, and then also those who have poor performance status. For patients who are platinum ineligible, the PDL status should be assessed, and they should be considered in for either immunotherapy or best supportive care, depending upon their overall clinical condition. So in order to summarize this talk, I would say that locally advanced bladder cancer is a condition, is a difficult condition to treat. They are often associated with variant histology. They're often associated with obstructive uropathy, and clinical staging is marred by poor, by inaccuracy in order, because the use of CT with contrast is difficult in patients with obstructive uropathy. MR is not as good, and often PET scan is unable to really define the correct local staging. So the management strategy should be individually tailored. And in my opinion, most patients are operable in the right hand. So if you have a center where there's significant experience in dealing with these patients can be operated quite safely, particularly if there is an issue with prolonged anesthesia and related effect. They should be considered for cutaneous ureterostomy, which is a fairly good and straightforward option for urinary diversion, and that really takes 1.5 hours less to operate on these patients. But it's important to remember that these patients would not be amenable to just cystectomy, and either use of neoadjuvant or adjuvant chemotherapy would be really important, and in certain situations, chemoradiation therapy would be ideal, particularly if you have variant histology. So I stop here and thank you very much